Thank you very much for the invitation to give this intriguingly titled talk, where we gaze into the future of what renal cancer clinical trials will look like over the next 5 years and also over the next 25 years. Here are my disclosures. So before we go into the future, let's talk about the past. So surgery trials have been questioned by outside observers, surgical researchers being critiqued by people like Richard Horton, who is the editor of The Lancet. In this now very famous article from 1996, he asks whether surgical research is indeed research or comic opera. There are questions but few answers, and that was because of the observation that by far the majority of research coming out of surgery was case series, about 50%, but they really are the weakest form of evidence. And actually, there was at that point in the 90s very little uptake for clinical trials, and this was holding surgery back. That has changed now, but we have seen a huge amount of bad science in surgical related research. You can see some examples here. On the right-hand side, the metal on metal hip fiasco with shards of metal going into the bloodstream. On the left, the mesh scandal causing untold problems in our patients. And of course, down on the right-hand side, the enigmatic Professor Paolo Maccarini, who implanted bits of rubber piping into the windpipes of his patients, resulting in the death of all but one of the people he operated on, and almost sinking the Karolinska Institute at the same time. So what's the situation been with renal cancer surgery related trials? Well, here's the National Cancer Research Institute portfolio map from 2015. And you can see in the areas relating to surgery, adjuvant, neoadjuvant, surgical related studies, there was a complete lack of any trials. But actually that meant that there was a great opportunity for those of us interested in surgery related trials in renal cancer to try and improve the situation. So one of the things that happened around about that time was that we set up the renal cancer surgical and interventional subgroup. You can see many familiar faces that were invited to be part of this at that point, including trainees, PPIE representatives, and pathologists and oncologists, as well as surgeons. So this became a very vibrant forum for the types of research we should move forward. We undertook some priority setting. This is work undertaken by my PhD student, Sabrina Rossi. You don't need to read through all of the different priorities, but these were done with a Delphi type of consensus statement. And there were clear areas from screening right through to prediction of response to neoadjuvant and adjuvant therapies that were seen to be areas that should be researched. So what will be the situation by 2025? Well, actually only 4 years from now, but what we expect for a start is that we're going to see more kidney cancer. It's one of very few cancers that's actually projected to increase in its incidence over the next 20 years. Most cancers are plateauing or even decreasing in their incidence, but that's not the case for kidney cancer. So we're not likely to be out of a job. What we'll be doing in 2025 is delivering the portfolio of 2021. And you can see here the map of the portfolio of clinical trials in renal cancer from early detection or screening, treatment of small renal masses, management of localized renal cancer, locally advanced renal cancer, follow-up and translational studies. And I'm delighted to say that things are somewhat different to how they were in 2015, when there were no studies to populate the various parts of the pathway. Now we have a study in virtually every domain. So let's start talking through some of these. The first part of the journey, if you like, is in early detection, and that is sometimes undertaken by screening. We don't have an early detection tool in kidney cancer, such as happens in prostate or ovarian cancer, let's say, with biomarkers. And so screening at the moment can only really be undertaken by addressing this in a part of our population, or by targeting based around clinical risk factors. And then we can decide whether individuals are at very low risk and don't require any screening, whether they are at quite high risk and should be imaged now, or in fact we can defer imaging for a later time. This is a concept that I've been exploring with Juliet Usher-Smith, who's an academic GP in Cambridge, and we have got to the point now of undertaking a feasibility study of screening, which I'll talk through with you in a moment. And the aim is that we will get enough information from that to decide whether a randomized controlled trial, a screening versus no screening, should eventually be undertaken to answer this question that's been going on for many, many years now. So the study that has been developed is called the Yorkshire Kidney Screening Trial, and this has been undertaken with colleagues in Leeds. The key individuals from a urological standpoint are John Cartledge and Mike Kamali, and their trainee, Anna Wright, who are running the triaging of all of the results. This is a study that's being undertaken as part of the Yorkshire Lung Screening Trial, which is run by Matt Callister, who you can see here, with Suzanne Rogerson, who runs the screening van. And effectively, individuals who are smokers and ex-smokers between the ages of 55 and 80 are invited to come for a lung scan, a non-contrast chest scan. And at the same time, these 6,500 people are asked if they would like to have their abdomen scanned with a non-contrast scan. By doing this, we will be taking on the world's first feasibility study of non-contrast CT scanning to evaluate the abdomen in an at-risk population. It adds about 10 seconds onto the scanning time, and has started in Leeds, and we've had several hundred people who have gone through the system now, and it seems to be well received. So we look forward to presenting the results to you in 2 years' time. Moving on to small renal masses, we will be delivering these studies, the EASE study, which is the European Active Surveillance Study, run by Steve Bromwich and Chris Blick, who are managing the UK portion of this study that's actually run by Alessandro Volpe from Italy. But the UK should recruit very well to this study of observation of biopsy-proven small renal masses. And then Maxine Tran's work around determining the optimal treatment strategy for small renal masses with the NEST cohort embedded study, where she will eventually get to the point of randomizing individuals to partial nephrectomy, ablation, and active surveillance, and possibly other treatments like SABRE in the future. What about neoadjuvant treatments? Well, we've recently completed the NAXIVAR trial. This was a study looking at IVC venous tumor thrombus and looking at whether or not neoadjuvant axitinib could downstage that disease, with an aim of trying to reduce the extent of surgery. This study recruited well. It recruited on time across 5 centres in the UK, and had a very rich translational biosample collection associated with it, which is being evaluated at the moment. The results are shown here. As usual, the best way to keep an eye on clinical trial results and major breakthroughs at meetings is to follow the meeting on Twitter. I presented the data from NAXIVAR at GU ASCO in February, and you can see that there was 31% response rate. We saw that 40% of people who were part of the study had a reduced extent of the surgery after 8 weeks of axitinib. We found that the approach was safe with comparable toxicity to other other axitinib-based studies. There was no increase in operative morbidity or mortality, and there didn't seem to be any significant disadvantages to offering neoadjuvant axitinib. There were a couple of metastatic patients who progressed with worsening metastatic disease, despite being on a very good agent, suggesting that they wouldn't have been well served by surgery. So this is a promising concept, and I think that we will now move to NAXIVAR 2. This is a study that is in design at the moment. potentially using the more novel VEGF TKIs in combination with immunotherapy, where we might see a more prolonged treatment course, better response, and probably follow-on adjuvant treatment that could be matched with this. Other window of opportunity studies, so basically neoadjuvant studies but shorter duration, are ongoing. One is another study that I'm running in Cambridge. This is called the WIRE study, Window of Opportunity in Renal Cancer. This is a study platform. At the moment, we're looking to recruit patients across 3 centres, Oxford, Glasgow and Cambridge. Any patient with a tumour that is actually larger than 4 centimetres is eligible and is a surgical candidate. They're offered therapy whilst they're in the window of opportunity, the up to 4 weeks that people normally wait for surgery. They're given new drug combinations up until the time of surgery. We're measuring the endpoints based on imaging, changes in the K-trans assessment on MRI. And for some of the later arms, we're measuring the effect of the agents using changes in immunohistochemistry. So very rich translational sampling, as you can see from this schematic. The agents are provided at the moment by AstraZeneca. Here they are listed. Cediranib's a VEGF TKI. We're very keen to offer our patients olaparib in addition to cediranib. Olaparib's a PARP inhibitor. We've got good evidence this should work well with a VEGF TKI. And we're also keen to see the combination of an immunotherapy in durvalumab with olaparib. These arms are given sequentially to different patients. It's not a randomized trial, but we are looking to see the endpoints very rapidly from this type of study. It's a clever Bayesian adaptive design designed by my colleague James Wason, who is a methodologist in Newcastle and also Cambridge. And you can see here the way this works. We recruit 10 patients to one of the combination arms. If we see 6 people or more responding, we would say that that's a positive arm and there's no need to recruit any more people. However, if we see very few responders, less than or equal to 2, we say that this enough patients have been put through this and that it's there's futility and we should move on to the next agent. If it's in between, we move on to recruiting more patients. So it's a clever way of being very efficient about our trial design rather than setting the number of patients right at the get-go that we need to recruit. Another adaptive trial design is the ongoing Rampart trial, which many of you will know about. This will definitely be still ongoing at 2025. In Rampart, it's a multi-arm, multi-stage design, much like Stampede, whereby we can change the control arm, we can drop arms or add new arms in as the evidence comes to us. There's been an exciting press release about adjuvant nivolumab that's going to be presented at ASCO in a few weeks' time. And it may be that we end up with an adjuvant option for treatment of our high risk and intermediate risk kidney cancer patients. If that's the case, the active monitoring control arm of Rampart will be contentious. And rather than scrapping the whole trial, it should be possible for us to swap in the new immunotherapy control arm immediately and continue to study the combination immunotherapy that you see there, plus add other arms in the future. So adaptive and additive trials are going to become the norm as we move into the future. What about follow-up? Follow-up's rather arbitrary at the moment. Work that Axel Bex has led that I've been involved with using the Recur database has shown that, in fact, we need to scan a huge number of people. For all comers, over 500 scans need to be undertaken before we identify one person with one potentially curable metastatic lesion. The remaining scans are all done without any chance of cure. Some of the other work from Recur suggests that there may not be a survival advantage to identifying recurrence on regular scans, and that puts into question the current follow-up regimens. Axel has been leading the design of a follow-up study to evaluate the current follow-up regimens with a more symptom and blood test based approach to follow-up, which I think is exciting. and we'll certainly rationalize follow-up and take it into the community. What about biomarkers for detecting response to therapies? Well, there are many that are being evaluated. ctDNA is an area that you will have heard of that is being used in clinical practice in some other cancers. This is the situation in kidney cancer. In more advanced disease, we can find ctDNA, and when it is identified, it is possible to track responses to various agents, which is effectively what the chart on the left is showing, that levels of ctDNA correlate with increases in with response or lack of response to various different systemic therapies. And indeed, when we find ctDNA, it can preempt the development of metastatic disease. This is one of my patients from Cambridge. You can see a high level of ctDNA at the start of the disease journey. After nephrectomy, it drops down, but not completely to an undetectable level. Then preempting the identification of bone metastases by about 3 weeks, an increase in the ctDNA, which then reduces again with drug therapy, as you might expect. So a possible avenue of treatment in the future. What about devices? So there are exciting new robotic surgery devices and other devices coming into urology. How do we best evaluate these? I showed you the issues that we saw with surgical trials in the past, and how do we best avoid these? There's a very clear research framework for medication, but less so for devices. But actually, there has been a nice framework developed now by the Ideal Collaborative led out of Oxford. The Ideal D framework has a very clear way of evaluating devices, from iterative device development right through to registries, which should be started early on in the evaluation of a new device, into large randomized controlled trials as well. So that's where we'll be in 5 years' time. But what about 2050? So obviously, we're all going to be much older. Hopefully, we'll still be standing. What does the crystal ball tell us about the future? Well, I predict that the work of colleagues of ours, such as Tom Mitchell, who's doing some sensational work with his team at the Sanger Institute in Cambridge, where he's found that actually kidney cancer appears to develop from in a few hundred cells in adolescence and the teenage years, with chromosome 3p loss, which slowly evolve over the next couple of decades, so that there are several hundred cells with these changes, and eventually a few unlucky individuals will have further mutations on the other allele, which mean that they develop kidney cancer cells, which then develop into larger tumors. One possible way of capitalizing on this finding is to target cells with 3p loss. Possibly, Tom thinks, by targeting co-deleted bystander genes on that chromosome arm, making them more susceptible to targeting. Number needed to treat to save one person from developing a kidney cancer is estimated to be between 50 and 100. We will have much better ways of screening, not just for kidney cancer, but for multiple diseases. Here are a couple of potential examples. Breath tests using volatile organic compounds. These studies are going on at the moment, and it appears that not just lung cancers, but other cancers will have volatile compounds released into the blood and then into the exhaled breath, which can be evaluated by mass spectrometry to pick up disease. Equally, one can imagine point of care tests using non-invasive approaches like urine to pick up a range of different proteins, which can drive us towards the detection of kidney cancer, perilipin-1 and aquaporin-2 being good examples in kidney cancer. But you can see a situation where other diseases would also be picked up using that same test. We will need to personalize systemic therapy use a lot more than we do currently. At the moment, we're using essentially in kidney cancer the skill of the oncologist to determine whether a patient should have a TKI versus immunotherapy versus a combination drug. So we will be using avatars. This is an example of a patient-derived xenograft in a mouse, a piece of kidney cancer sutured to the capsule or under the capsule of a mouse kidney. But of course, we also need to factor in the role of the immune system. So humanized mouse models are being developed at the moment where the tumor grows, but also the human immune system is transplanted into the mouse to allow us to evaluate whether that patient is going to mount an immune response to drug treatments like immunotherapy. Artificial intelligence is the buzz at the moment, and that will come to fruition over the next 30 years. There'll be better ways of delivering clinical trials. We'll be able to generate lists of patients who are most likely to be, who are eligible based on their genetic makeup, their clinical characteristics, and those will all be rationalized by an artificial intelligence generated approach. And actually, this could also develop a real world data derived control group rather than us needing to have an actual control group for every trial. There'll be new ways of delivering clinical trials, of monitoring people. Wearables will become, the power of the wearable will be leveraged. The information on your Apple Watch now can tell you your heart rate, your oxygen saturations, your ECG, and those abilities will only be enhanced. It will allow us to determine outside of the hospital how people are responding to drugs, whether they are still fit enough to have these medications, how much they're able to mobilize, what their vitals are. And it will allow us to rapidly interact with people so that we can change the medication that they're getting as necessary. It's likely also that phase 1, 2, and 3 trial model will also be replaced with something more efficient. So I've put a few predictions down there. Who knows what the future really will hold, but there are going to be some clear constants. We're still going to have patients, and potentially lots of them. I've said at the beginning there that we are going to see more people with kidney cancer. We're going to see these people with kidney cancers. We're still going to see aggressive kidney cancers with the potential for metastasis. And so there's still going to be a significant role for surgeons, oncologists, pathologists, radiologists working together to treat our patients and try and hopefully be in a better situation to offer cure to a larger range of people. So thank you very much for listening. I'm grateful to my colleagues listed here who have given me some inspiration for my crystal ball gazing for the future. Thank you very much.